Good morning. Myself Gupta Tanmay with Hator Aditya Subhash will be reporting on corneal trauma, which includes corneal foreign body, corneal abrasion, corneal laceration, corneal perforation, corneal rupture, and penetrating injury. Firstly, we'll be starting with some basic points rega- uh, regarding the corneal injuries. The most common corneal injuries are due to the foreign body abrasions. Corneal abrasions usually heal rapidly without the serious consequences, but deeper corneal involvement, infection, or poor healing may result in the irregularity of the corneal epithelium or scar formation within the stroma. These corneal lacerations, rupture, and perforations are usually rare and associated with severe mechanical trauma, such as road traffic accident or with fingernails, animal nail scratch, accident with the hand power tools, high power lasers or thermal machines, or high velocity projectiles, etc. Moving on to the anatomy of cornea. The cornea is a transparent front part of the eye that covers the iris, pupil, and the anterior chamber, along with the anterior chamber and the lens. The cornea is avascular to be the transparent, and the nutrients are transported via diffusion from tears from outside and the aqueous humor from inside. The cornea is innervated by the nasociliary nerve, which is subophthalmic branch of the trigeminal nerve. We can see the six corneal layers in this image. The first one is called the corneal epithelium, the second one is called Bowman's layer, third one is called corneal stroma, fourth one is called Duval's layer, fifth one is called descendant's layer, and the sixth one is called corneal endothelium. Sorry. Firstly, we'll be starting with the corneal epithelium. This layer is non-keratinized. It has three strata: superficial, middle, and basal. Superficial is composed of squamous epithelium, middle one is composed of polygonal epithelium, and the basal is composed of columnar epithelium. The second layer is Bowman's layer. This layer is acellular, it cannot regenerate. This layer heals by scar formation. This layer is tough layer composed of collagen, mainly type 1 collagen fibrils, laminin, nodogen, perlecan, and the other HSPCGs that protects the corneal stroma. The third one is corneal stroma. It contributes to the 90% of the total corneal thickness. Most common type of collagen is type 1 in this layer. And the most common type of glycosaminoglycans are keratin sulfate. The corneal stroma consists of approximately 200 layers. Each layer is 1.5 to 2.5 micrometer. This layer consists of crystallins, which reduces the backscatter of the light. Moving on to the fourth layer, that is Duval's layer. It is the strongest layer of the cornea, which thickness ranges from 7 to 14 microns. The next one, fifth, is descendant's layer. It is a thin cellular layer that serves as a modified basal membrane of the corneal endothelium from which the cells are derived. This layer is composed of mainly of collagen type 4 fibrils, less rigid than collagen type 1 fibrils, and it is around 5 to 20 micrometer thick. It is secreted continuously by underlying endothelial cells. This layer can regenerate. Its thickness increases throughout the life, and the peripheral termination of this membrane is known as Schwalbe's line. And the sixth one is corneal endothelium, which is innermost or the posterior. This single cell layer, monolayer, composed of the simple squamous or the cuboidal cells. This layer is metabolically active and helps to maintain the corneal transparency by regulating fluid and solute transport between the aqueous and the corneal stroma compartments. Unlike the corneal epithelium, this layer cannot regenerate. Now moving on to the epidemiology. We divided epidemiology into the 6 different groups: age, gender, occupational hazards, contact lens wearers, geographic location, and the sports related injuries. So starting with the age, both corneal abrasions and the corneal trauma can occur at any age, but they are more common in the children and young adults due to their participation in the sports and the other activities that increase the risk of eye injury. Now the next one, gender. The men are more likely to experience corneal abrasions and the corneal trauma than women due to their higher participation rates in the contact sports and the other high risk activities. The third one is occupational hazards. Occupations such as construction workers, welders are at higher risk of corneal trauma due to the exposure to the flying debris and particles. Contact lens wearers using contact lens have a higher risk of corneal abrasions. Females are more likely affected than males. Geographic locations. Corneal abrasions and the corneal trauma can be more common in the rural and the deserted areas due to the constant muddy and the sandy environment. And some sports related injuries. Sports-related injuries are common in corneal abrasions and the in corneal trauma. Some activities such as sports such as basketball, football, and the baseball, they are the most common, higher risk. Now moving on to the pathophysiology. Corneal abrasion is a defect in the surface of the cornea that is limited to the most superficial layer, the epithelium, and does not penetrate the Bowman membrane. Corneal abrasion results from the physical or the chemical trauma. Severe corneal injuries can also involve the deeper, thicker stromal layer and can result partial thickness, corneal laceration, or the rupture. Cornea is fragile and can be easily damaged. The corneal epithelium is richly innervated and therefore is very painful when an injury occurs. The epithelium regenerates quickly, with most abrasions healing within 24 to 48 hours. For chemical eye injuries, the extent of damage depends on the substance. For alcohol-related injuries, the de-epithelialization of the ocular surface will usually heal with no further consequences. Acids will cause tissue proteins to bind to acid molecules, which then neutralizes the acid, causing the coagulation and the tissue necrosis. Alkali ocular injuries are more numerous and cause hydrophilic and the lipophilic degeneration. Now the next part is clinical presentations. Discomfort is seen, redness and inflammation is seen, sensitivity to light is present, tearing discharge is seen, blurred vision is the problem. So that's all in the clinical representations. If we explain pain and discomfort, corneal injuries can cause pain, burning, or a foreign body sensation in the eye. The pain may be mild or severe depending on the extent of the injury. For redness and inflammation of the eye, it can be localized to the affected area or involve the entire eye. There can be blurred vision, especially if the injury affects the central part of the cornea. Severity of the vision loss can vary depending on the extent of the injury. Corneal injuries can cause sensitivity to the light or photophobia due to the inflammation, the irritation of the cornea. And injuries can also cause increased tearing and discharge from the eye. This is a sign of inflammation and irritation. Now, what are the important things to ask while taking history? Firstly, we'll talk about the injury. Ask patient how the injury occurred and what caused it and when it happened. Then the symptoms. Ask about the symptoms experiences such as pain, redness and tearing, blood vision, or the sensitivity to the light. Then about the medical history of the patient, that especially those that affect the eyes of vision such as diabetes, glaucoma, or the previous eye surgeries. Then about contact lenses, if a patient wears contact lenses or not, and if they do wear the contact lenses, and then how long they've been wearing them. And then we can ask the patient about any allergies to the medications or the substances that can affect the choice of treatment, about any occupational or recreational history, and the last one, family history. Workup and diagnosis. Starting with hyphema, most common finding. Then the iridodenesis, finding of tremulous iris, ectopia lentis, partial subluxation of lens, iridodialysis, detachment of the root of iris from the ciliary body or D-shaped pupil can be seen. Slit lamp examination, that is specialized microscope that is used to examine the cornea and the other structures of the eye. The slit lamp can help detect abrasions and lacerations or other signs of trauma. Fluorescein staining. Fluorescein dye is used to stain the surface of the eye. Dye can help detect the corneal abrasions or the other injuries by highlighting areas where the corneal epithelium has been disrupted. Tonometry. This test measures the pressure inside the eye and can help to detect any changes that may indicate the damage to the cornea or the other structures of the eye. Ocular CT scan. Investigation of the choice for the foreign body damage. Bacterial culture. If a corneal ulcer, example microbial keratitis, is suspected because of the prolonged symptoms and risk factors such as the contact lens wear. Now to the medical management part. Copious irrigation of eye using balanced salt solution of the ringa lactate by the double eversion of the eyelids to reach the fornices of the eye. Topical antibiotics to prevent the secondary infection. Atropine for ciliary spasm. Lubricating eye drops to help in epithelial regrowth. topical sodium citrate to prevent the proteolytic activity, NSAIDs and analgesics for the pain and inflammation control. Next, surgical management, corneal suturing. In cases of the corneal laceration, the edges of the wound may be approximated using the sutures. This can help prevent infection, promote healing, and maintaining the structural integrity of the cornea. Next, corneal grafting. In cases of corneal rupture or significant tissue loss, a corneal transplant may be necessary. This involves removing the damaged portion of the cornea and replacing it with the donor tissue. Tissue adhesive. Tissue adhesive may be used to close the small corneal laceration. This can be less invasive, alternate to suturing, and may promote the faster healing. Amniotic membrane transplantation. In some cases, amniotic membrane may be used to promote the healing and reduce scarring in the cases of the corneal trauma. The membrane is typical harvested from donated placentas and applied to the surface of cornea. Vitrectomy. In cases where the vitreous gel inside the eye is contaminated by the injury, a vitrectomy may be necessary. This involves removing the contaminated vitreous gel and replacing it with a clear sterile fluid. Now to the end prognosis part. Factors that may affect the visual prognosis of the corneal rupture. The prognosis of the corneal trauma depends on the severity and the extent of the injury and the effectiveness of the treatment. Minor corneal abrasions and the lacerations have a good prognosis and typically heal within a few days to a week with appropriate treatment. However, some more severe injuries such as corneal ruptures or perforations can result in permanent vision loss if not promptly and appropriately treated. In these cases, surgical interventions such as corneal grafting or suturing may be necessary to restore the structural integrity of the eye and prevent complications such as infection or scarring. Complications such as infection, inflammation, or scarring can also occur after the corneal trauma, and these can affect the prognosis. The use of appropriate medications such as antibiotics, anti-inflammatory drugs, and cycloplegics can help prevent or manage these complications and improve the overall prognosis. Size and depth of injury. Larger and deeper corneal ruptures are more likely to result in a permanent vision loss as they can affect more of the corneal tissue and the potentially damage deeper structures in the eye. Location of the injury. Corneal ruptures that occur in the central or the visual axis of the eye are more likely to result in the permanent vision loss as they can directly affect the visual acuity. Underlying conditions. Underlying conditions such as the diabetes, autoimmune disorders, or previous eye surgeries can affect the healing process and the overall visual prognosis. Here are some differential diagnoses which can be correlated or confused with corneal trauma. First one is ulcerative keratitis and the second one is endemic keratoconjunctivitis. That's the end of our report. Thank you for listening.